Yeah, hi, everybody. This is the remaining portion of this additional review. It's basically the same thing. Maybe I'm just including a little bit more since I've just been there with it. So let me allow me, as it were, to get to the next page. And we will get it started. Here we are. Okay. So as you recall, it basically stopped right around the start of insulin and diabetes, etc. So first of all, noteworthy thing. I'm not going to get into everything that I went into with the glucose tolerance tests and curves, etc., etc. To any extent, I'll look through this. Where is it? First of all, this is the marriage of the endocrine system in homeostasis, as well as expressed anywhere. And these are two independent groups of effectively groups of glandular tissue, one called alpha cells, which make glucagon, one called beta cells, which make insulin, that function in the islet area, which is sort of the external area of the pancreas, where it's readily secreted into the bloodstream. The glucagon works directly on the liver to do glycogenolysis and act to increase gluconeogenesis to raise blood sugar, where insulin works everywhere effectively. To remove blood sugar from the bloodstream, bring it into the cells for the purpose of uh, energy transformations and fueling metabolism. Right? Basically, that's it. So you should know where they are and what they do. Glucagon raises it, insulin lowers it vis-a-vis blood sugar. So you have to look at all of those kinds of factors. So to me, it's always been that insulin can have dramatic effects. And people with dramatic effects, that's immediately a risk factor for diabetes. They would fall into pre-diabetes. You're seeing a whole lot of TV now with pre-diabetes and stuff like that. I still think they're trying to sell Ozempic. But what it really means to me is that to some extent, it softens the blow. Basically, you don't have quite as many extremes. If both systems are working in concert, when insulin causes a sudden drop, the glucagon kicks in, so it does not become an extraordinarily dramatic drop that can lead to immediate hypoglycemia. And the same is true for excessive amounts of glucagon. There'll be immediately insulin will be triggered, and that will slow that down. There's some problem with regard to fight or flight. I'm fond of saying living systems don't typically make sharp turns, and when they do, it's a problem. So when we talk about the different kinds of diabetes, for years we had maturity and juvenile. And, juvenile by definition was under 40, maturity was over 40. Now we just classify them as type 1 and type 2. And type 1 is based on problems with regard to insulin. Typically, it's either being produced insufficiently or conceivably not at all, or in some form where there's an inherent fault in the insulin itself. Versus type 2, which is more receptor based. This is the inability for the insulin to effectively make its way into the cell. The insulin is there, but the mechanisms to deliver the blood sugar, not insulin into the cell, but the blood sugar into the cell, for the insulin to attach and for the blood sugar to be facilitated into the cell. And we've gone away from maturity and juvenile onset because we realize that they are realistically can occur at any time with anybody. So you could have quote unquote type 2 diabetes in a juvenile or type 1 diabetes in someone who's mature. The reality is there's probably, I think, less true type 1 diabetes than type 2. Our understanding is increased over time. There's a lot of factors that can damage insulin producing cells for the beta cells and the islets and the pancreas. There's a lot of factors that can cause significant problems with the ability for the receptors. That was for years, that was called syndrome X or metabolic syndrome. And indeed we're seeing an increasing amount in mature people with insulin dependent type 1 and a strikingly increasing amount of type 2 in younger individuals. This is that sedentary lifestyle, the lack of activity, poor diet, snack foods, video games, sitting there doing a whole lot. A And we have to understand that. I think, sociologically, with so many of our world based around computers and internet, we spend a whole lot of time, like we all do here in school, looking at computer generated images and doing our work on computers and all of those types of things that are there. So it's totally different compared to what it was like, if you can imagine the pre-computer age we're talking about. It's the old when I was a kid growing up, which is very much different. So those are all significant. So what is it? High levels of it, basically symptomatic hyperglycemia. You have high blood sugar levels, and you have a variety of symptoms. Typically, increased urination. The all three: increased urea, polyuria, polydipsia, polyphagia, fatigue, increased urination, increased hunger, increased thirst, poor energy utilization. Okay, and we really worry about vis-a-vis when we have a lack of control in diabetes is the fact that now we're having to unintentionally utilize fats, and diabetics generally are not changing their diet, so they're having, not only are they utilizing fats, uh, now you have an abundance of sugar in the system that's not being used, and that's creating its own subset of inflammatory problems. And effectively what's happening when you use fats, and unfortunately a lot of the fats are the wrong kinds of fats, they form those that are called keto acids, and they bang together. And again, it's that beta oxidation you're very familiar with from cell and molecular, and the way the body metabolizes fats. They short chain, very tiny short chain fatty acids bang into each other. They form ketone bodies and keto acids, and they are part of the linchpin for what eventually lead to atherosclerotic depositions. And it's complicated by the sugar, which is pro-inflammatory, which feeds inflammation. And that's where we can see a tremendous amount of blood vessel disease. Again, with the type 1, we have the other factor of that being autoimmune in origin. And with that, now you're immediately having an immunological fault. And particularly, you're developing these depositions of antigen antibody complex in the kidneys, beginning to take away their function over time. And then you have the blood vessel limitations. It's just a horrible disease. You really don't want to deal with it. Once again, the kidneys are impacted by this. And so what do we see in diabetics or people with poor kidney function? We see anemia because they can't produce erythropoietin. Okay. That's very, very significant as well. And most of the patients I had treated who were anemic were also diabetic. And now you have a vicious cycle. You have poor circulation, visual loss, and they can't really change it. The exercise is almost out of the question. It really, once you get to what we call in the world of diabetes, end organ disease, where you begin to see the eyes and the lack and affecting the nervous system and the kidneys and the heart. It's just not going to work out well for anybody. Pardon the chair, I'm in the office. Other hormones of note. Leptin playing a significant role, that's produced by fat cells, and that plays a big role, as you will see, when we start to get the female reproductive and the triggering thereof. Other hormones of significance: atrial natriuretic peptide. Basically, the atria, when they're stretched, immediately suggest high blood volume. So they're able to secrete a hormone. Natriuretic means get rid of sodium in the urine. That sort of counteracts aldosterone, opens passageway for sodium to leave the system and get into the urine, and water will follow it. So that's all of those types of things. Don't forget the role of the thymus. We'll get to that immune system soon, but that's still an endocrine gland. And that endocrine gland produces thymosins, which work very effectively on their own cells and on the white blood cells that are contained within the thymus to lead to their maturity. So now we get more or less, probably focusing more on autonomic nervous system. And if there's one thing you have to memorize, it's all the effects of fight or flight. If you know fight or flight, that's sympathetic. Anything that does is sympathetic. That's as close to pure sympathetic as possible. And the opposite is parasympathetic. So think what happens when fight or flight. Your eyes widen so you can get the big picture. Your secretions dry up so you're able to breathe without impact from mucus and saliva that are there. Your heart accelerates, your breathing accelerates, you're pumping out more blood that's there. You're generating uh, effectively a cooling mechanism by increasing perspiration to your skin because you have to dissipate heat. Your blood vessels widen going to the heart, your blood vessels widen going to skeletal muscle. They narrow everywhere else except for the brain, which is constant. So you're basically redirecting the most of your blood flow to heart and skeletal muscles. You're leaving enough blood flow to the genitourinary and the gastrointestinal system to keep it functioning. That's the way it works. That's the major effects. So eyes wide open, hair standing on end, perspiration to cool, rapid breathing, rapid heart rate, high blood pressure, you name it, you're retaining all the fluids you can because you want to keep it in the bloodstream. All of that and all of the blood vessel related phenomena is sympathetic. There are no parasympathetics in the smooth muscle walls of the blood vessels. It's all sympathetic. So we have what's called sympathetic tone. The best way to analyze that is to look at, or to really to judge if it's being effective and at the right area, is to look at the diastolic blood pressure. That's the marker for sympathetic tone. The resting tension in blood vessels. When that starts to rise, that's when heart problems and blood pressure problems and blood vessel problems really start to ascend. Can't emphasize that enough. Okay, so that's known as the action division, fight or flight, where the rest and digest is parasympathetic. Just think of it. You're resting, you're sitting, you're doing what I'm doing now, you're watching TV, you're sitting at your computer. The opposite. Your blood flow returns to normal. Your eyes are typically doing close work. There's a lot of basically that's when your body takes care of business, digestion, genitourinary function, etc. Okay, so no, I have several questions. Say in fight or flight, what do these do? So just be aware of all of those things. Don't forget that epinephrine and norepinephrine, the impact they have on those beta 2 receptors in the respiratory passageways. It's the oddball. It's like acetylcholine. It's like acetylcholine being released by the sympathetics, but causing your hair to stand on it and causing you to perspire. The oddball with beta 2s, both with regard to, and particularly with regard to respiratory activity, is that they bronchodilate. Most of the other vessels constrict, but they bronchodilate. The same thing for the blood vessels going to the heart and to the skeletal muscles. There's a dilatory effect, would be the way to express it. So know about pre and post ganglionic. Those are important terms. They're the terms that I use. So it's a 2-nerve circuit. The ganglions in the middle. All pre-ganglionic fibers, cholinergic. They release acetylcholine. Okay. All post-ganglionic fibers of parasympathetics, acetylcholine. Again, by definition, you have cholinergics, and those are also called nicotinic receptors. Then we get to muscarinics, and we'll get to that just in a second, that are there. Muscarinic is, again, the other chemicals that are there, and we begin to see those a little bit differently. Postganglionic nerves all release acetylcholine. The distinction, nicotinic receptors are also, they're found in both. So if it's all preganglionic, that's sympathetic and post-sympathetic. Okay. Nicotinic receptors are in both locations. The muscarinics are in the post-ganglionic parasympathetic fibers. And then the adrenergics, the ones that release epinephrine and norepinephrine, other than that one oddball going to sweat glands, those are in the postganglionic nerves at their target structures, which are principally norepinephrine, and again the oddball again, and that is the adrenal medulla, where it's epinephrine and norepinephrine both. So you've got to be aware of those things. Adrenergics have alpha, betas, even gammas. They're different subsets. You should be familiar with the major issues they have. Not issues, but the major category, the major things that are in it, what they do. Where you have beta ones, increasing heart rate, force of contraction, beta two, more dilatory, that kind of stuff that's there. Okay. So, and obviously we utilize those effects, and that's when we get to sympathetic and parasympathetic mimicking agents. Remember, the terminology is important. Parasympathomimetic and sympathomimetic. Epinephrine sympathomimetic. It mimics the sympathetic. So when you give that to somebody with an EpiPen, you're trying to mimic that effect, principally bronchodilation, because typically we're dealing with anaphylactic shock, nut oils, bee stings, and the like. So parasympathomimetics, we're trying to mimic that activity. Well, for a long time, to elevate heart rate, we use something called atropine. Okay. And that was a parasympatholytic. We're trying to elevate the heart rate intentionally. And we have different ways of doing that now. Okay. So all of those are significant. So beta adrenergics, type ones on the beta ones, and again, the beta ones versus the beta two, heart rate and force of contraction. Beta two is again the one that has more of the direct response of vasodilation and bronchodilation that are there. So be familiar with all of those. And again, the adrenal medulla is effectively, think of it as the ganglion. I think that's the best way to understand it. That's where that one of the few, really the only long preganglion. Remember, preganglionic fibers. The nerves are very short in the sympathetic, except for that one, which goes to the adrenal gland. And the parasympathetic, they have long, almost all of them are categorized as long preganglionic and relatively short preganglionic. Effectively, other than the adrenal medulla, the sympathetic is short preganglionic and long postganglionic. So again, the big player in any type of blood vessel, and by implication the kidney, is always the sympathetic. And I think that's basically everything you have to know for that. Again, it's 50 questions. I think it's not. I think if you know fight or flight and know what I've gone over here, I think you have it down relatively easily. So thankfully, I have concluded this review, and now I'm going to do this. Stop